Look at the physical reality of an intensive care unit. A patient in severe respiratory failure requires continuous mechanical intervention and invasive monitoring simply to maintain basic physiological function. This monitor illustrates the clinical presentation of systemic inflammatory response syndrome, or SIRS. We define this state through exact physiological parameters: a core temperature above 38 or below 36 degrees Celsius, a resting heart rate over 90 beats per minute, a respiratory rate exceeding 20, and an abnormal white blood cell count. When these specific SIRS criteria are triggered by a documented infection, the clinical diagnosis escalates to sepsis. Yet there is a core biological paradox at play here. The profound hemodynamic collapse observed on these monitors is not directly inflicted by the invading pathogen. The lethal shock state threatening this patient is driven by the host's own dysregulated immune response. To understand how a bacterial infection leads to widespread multi-organ failure, we must reverse engineer this systemic collapse back to its exact origin: a localized immune defense operating inside a single alveolus. The initial site of infection begins in the pulmonary tree. Inhaled bacteria, such as Streptococcus pneumoniae, travel down the trachea, through the branching bronchioles, and settle deep inside the terminal alveoli. Here, the multiplying bacteria physically breach the delicate alveolar epithelial barrier. Waiting for them in the interstitial space is the first line of innate immune defense, the resident alveolar macrophage. This highly localized, microscopic encounter between a macrophage and a bacterial cell is the exact ignition point for the systemic cytokine storm that will threaten the patient's life. Invading bacteria carry specific molecular signatures on their cell surfaces, known as pathogen-associated molecular patterns, or PAMPs. This diagram shows macrophage toll-like receptors binding the specific geometry of bacterial PAMPs. The macrophage then physically engulfs and dismantles the pathogen internally. Finally, it executes antigen presentation, displaying fragments of the destroyed pathogen on its surface using an MHC2 molecule. This specific MHC2 presentation bridges the innate immune response to the adaptive immune system, allowing circulating helper T lymphocytes to read the antigen and mount a targeted defense. This mechanism of pathogen recognition is highly specific and strictly localized. It is biologically designed to contain the bacterial threat entirely within the alveolar space. Simultaneously, this innate immune recognition triggers the complement cascade, a complex biochemical enzyme system circulating in the blood. In this visualization, complement protein C3b coats the bacteria. This opsonization drastically enhances the macrophage's ability to phagocytose invaders. The terminal step is the assembly of the membrane attack complex, which directly lyses the bacteria by punching holes through their cell walls. While complement attacks bacteria directly, activated macrophages release the first wave of local cytokines into the surrounding tissue, specifically TNF-alpha, interleukin-1, and interleukin-8. These specific chemokines establish a chemical concentration gradient. This signals circulating neutrophils to decelerate, roll along the endothelium, and physically squeeze through the capillary wall. Up to this exact moment, the inflammatory exudate, localized cytokine release, and complement activation represent a perfectly functioning immune defense actively clearing the pneumonia. But the severity of the infection eventually pushes the local environment past a critical tipping point. The concentrated soup of cytokines escapes the alveolus and spills massively into the pulmonary capillaries. This systemic cytokine storm is the exact biochemical driver of the clinical SIRS criteria we initially observed on the bedside monitor. Exposed to circulating cytokines, systemic endothelial cells release massive quantities of nitric oxide. Alongside prostaglandins, this forces the vascular smooth muscle to relax, drastically widening the arteriole. This graph shows the consequence. As the vessel dilates, systemic vascular resistance and blood pressure plummet. This unchecked vasodilation is the exact definition of distributive shock. The heart may still be pumping with adequate force, but the vascular pipes have dilated massively. Systemic perfusion pressure can no longer be maintained. The physiological collapse then moves downstream to the capillary beds, where inflammatory mediators directly attack the tight junctions binding endothelial cells together. Using the Starling equation, hydrostatic pressure pushing fluid out normally balances oncotic pressure pulling it in. As tight junctions widen, the reflection coefficient drops. Proteins escape, destroying the oncotic gradient. Unopposed hydrostatic pressure continuously drives massive fluid into the interstitial space. This severe interstitial edema actively depletes the patient's circulating intravascular volume, exacerbating the already dangerous hypotension. The combination of profound vasodilation and this massive capillary leak locks the patient into a lethal, refractory hypotensive state. Widespread endothelial damage has a secondary effect. It exposes the underlying tissue factor to the circulating bloodstream. This exposure triggers the extrinsic coagulation cascade on a massive, systemic scale, rapidly filling the microvasculature with chaotic webs of fibrin and trapped platelets. Unchecked microvascular thrombosis physically blocks blood flow to the end organs, causing focal, widespread cellular ischemia. This diagram illustrates the resulting consumptive coagulopathy. The continuous, unregulated creation of clots rapidly depletes the body's entire store of platelets and clotting factors. Simultaneously, circulating inflammatory mediators actively suppress natural anticoagulants like protein C, preventing the body from halting the runaway clotting cascade. This is disseminated intravascular coagulation, or DIC. It is the failure of localized containment. A biological mechanism meant to trap bacteria in a wound instead starves organs of blood and leaves the patient highly vulnerable to catastrophic hemorrhage. Deep inside the tissue cells, the combination of DIC and profound hypotension severely restricts oxygen delivery. Deprived of oxygen, mitochondria abandon the citric acid cycle, diverting their metabolism entirely into anaerobic glycolysis. This shift produces a massive cellular buildup of lactate. Spilling into the bloodstream, it drives the patient into a profound clinical lactic acidosis. While peripheral organs suffocate, the systemic capillary leak syndrome manifests fatally in the pulmonary vascular bed. Protein-rich fluid floods across the damaged alveolar membranes, drowning the remaining healthy lung tissue, generating bilateral opacities and severe hypoxemia. This clinical presentation is the exact Berlin definition of acute respiratory distress syndrome. The localized pneumonia has bred a systemic cytokine storm, which has now returned to destroy the lung tissue, completing the mechanical cycle of multi-organ failure. Sepsis is the ultimate systemic overreaction. The immune system utilizes vasodilation to deliver leukocytes to a local infection, but when scaled systemically, it destroys the blood pressure and causes distributive shock. Capillary permeability allows immune cells to migrate into tissue, but when activated globally, it drains the intravascular volume and drowns the lungs in fluid. Coagulation effectively traps pathogens in a localized wound, but widespread systemic activation drives ischemic organ failure and severe bleeding. Treating sepsis requires managing this exact biological threshold. Medicine must artificially support the patient's hemodynamics long enough to buy time for the immune system to clear the pathogen before the defense mechanism destroys the host.